Okay, it's a real pleasure to be here, and I hope you guys all got that answer right on that first one. And so it'll be obvious what my choice is. I'm arguing the pro that we should be doing something other than novel agents in these patients. Now, follicular lymphoma, I'm not going to introduce this, but as you can see, there's a very varying prognosis of patients based on their FLIPI score, and this might be somewhat better with rituximab-based treatments, but you can still see there's patients who do poorly. And in fact, if you take patients who progress, despite any treatment, there's about 20% or more that progress within 2 years. And this is a poor prognosis group. This is with R-CHOP, this is with BR versus R-CHOP, and this is actually even in rituximab maintenance. And this suggests that there's a high-risk group of patients who relapse early despite your best efforts to get them into remission, and even with maintenance. So I'm going to argue that that's a bad group. Now, this is a very interesting study from the National Lymphocare Registry, where they took patients who had follicular lymphoma that were reported, and they selected this group that had frontline R-CHOP chemotherapy. And they split this group then into those who progressed within 2 years and those who did not. And quite surprisingly, this was the outcome. So this is the survival of patients who progressed early versus the group that did not progress early. And you can see that the median survival here is very short. So I would argue that this group is very, very bad. So you don't have time to fool around with novel agents in this setting. You need to move to more aggressive therapy. Now, this was then taken to a confirmatory group at the Mayo, and they had exactly the same thing. So this is not progression-free survival. This is overall survival. Okay, so this is poor. So this group, you could argue, has bad prognosis. You can identify them pretty quickly within a couple years of treatment, and you might be able to do something about it. So it represents about 20% of treated patients in multiple trials, poor survival, and could intervention do something? Well, this is the data with auto transplant in first remission. This is from the Dana-Farber Cancer Series, and you can see that there seems to be a plateau on the curve even with auto transplant. This is data from the British group, again showing disease-free survival at least, suggesting that there could be a cure rate with auto transplant if done early. Now, the problem here is that with auto transplants and the way they were done in these studies using high-dose TBI, there was a cumulative incidence of second malignancies, which approached up to 15 to 20%, depending on how long you waited. The other thing I want to say is that the auto transplant results are dependent on when you do them. So if you're going to do an auto transplant, the sooner you do it, generally the better. If you wait until people are completely refractory to all known chemotherapy, then this is the data from the Nebraska series. So if you've had failed 3 or 4 prior therapies, transplants don't work. So certainly if you're going to consider doing an auto transplant, I wouldn't do it after multiple relapses, and you could argue that you would do it sooner. So in general, auto transplants are often used for patients who have relapsed but chemosensitive disease. The long-term outcome is improved if you give it early and worse if after greater lines of therapy. There's a low risk of secondary malignancies when you use a non-TBI based regimen, and that's why now everyone uses essentially BEAM or a variation on the same. There may be tumor contamination of the auto cells, which contributes for patients who are relapsing especially early. And frontline consolidation with an auto transplant failed to improve survival. So why would that be? Well, I would argue that's probably because you transplanted about 80% of people who didn't need it. And if you had transplanted just the 20% who were in the worst group, then this could be a positive study. Obviously, it's not been shown. So what about an allo transplant? So that's the other choice here. There are a number of advantages of an allo transplant and a number of disadvantages. It's a tumor-free source. You get healthy hematopoietic stem cells, and you actually get a healthy immune system. You do get immune-mediated graft versus tumor activity, and you have a very low risk of relapse, especially in follicular lymphoma, which it approaches 0 risk of relapse after a year or 2. But there are big disadvantages for sure. Higher non-relapse mortality, which can approach 15 to 40%, depending on what age group you're talking about. There's clearly a risk of graft versus host disease. There's prolonged immunosuppression and resulting in infections. And we often can't use myeloablative conditioning except for young patients. So there are many types of conditioning regimens that can be used, and they can range from these very low-dose regimens, where all the tumor activity is from graft versus tumor action, to the myeloablative approaches. And this is the one we've used in Seattle. This is, we developed this flu-TBI regimen, which is just 3 doses of fludarabine, 1 fraction of total body radiation, and then stem cells from an HLA-matched donor. And this just basically swaps your immune system with the donor, and all of the anti-tumor activity is from graft versus tumor effects. So the conditioning intensity just really provides this immunosuppression to allow the engraftment of the donor. There's minimal direct anti-tumor activity, and this allows treatment of patients up into their 70s and 80s, or even following a failed auto transplant. The donor system, the donor immune system, and these are the T cells in the donor, provide rejection of host hematopoiesis, and that causes graft versus tumor activity as the immunosuppression is withdrawn, and the major risks are, again, graft versus host disease. So here's data from our center looking at patients with multiply relapsed follicular lymphoma. The median number of regimens here was over 5. So this is not the group I'm talking about, but this is the progression-free survival curve. And you can see that there's virtually no relapses if you can make it out a year or 2. But in the first part of the first 2 years, then there's clearly a risk both from disease progression, which is quite low, and from toxicity, graft versus host disease, and infection. Now, we're not the only ones to show that. This is the MD Anderson group, and they're showing 70 to 80% survival in patients receiving allografts. This is with using a fludarabine Cytoxan plus rituximab conditioning, with or without essentially Zevalin. And you can see there's many centers that have reported results in here. Now, the problem is we don't have very many randomized studies about what to do. But in general, we think that follicular lymphoma is very sensitive to these GVT effects. The reduced intensity conditioning is sufficient in most cases, very, very low relapse rates. It certainly provides the possibility of a cure and can be used after a failed auto transplant or later in the disease course due to its higher non-relapse mortality and risk of GVHD. Now, if you transform to large cell lymphoma, then patients do about the same as if they had de novo diffuse large B-cell lymphoma, or it's much more dependent on being in remission. So what should you use? Should you do an auto? Should you do an allo? Well, I think that for an auto, a transplant should be considered early after relapse after R-CHOP chemotherapy. And if you have chemosensitive disease, it can be safe with low non-relapse mortality, may provide long-term disease-free survival, and there's an ongoing risk of relapse, though, after an auto in most patients. The allo provides a curative option in more than 50% of the patients, but is a higher risk. Now, do we have any data that suggests one is better than the other? This is an EBMT analysis of registry data of 875 patients treated with a first transplant for follicular lymphoma. Now, again, not in first remission or second remission, and you can see the reduced intensity allograft actually takes a hit early and then has a potential benefit later in terms of progression-free survival. You can see, again, the allo has more risk in terms of non-relapse mortality, but if you look at relapse, virtually nobody relapses in the allo. And look at survival, you get out to 6 or 7, 8 years, it's kind of a wash. So it's really hard to know. If you're going to wait another 20 years potentially, maybe the only people alive will be patients who've had allo transplants, but clearly it's hard to make a call on this. We did actually have a semi-randomized study. This was the BMTC trial of donor versus no donor for patients with relapsed follicular lymphoma. They had no prior transplant. They had to have a match-related donor, and there were only 30 patients enrolled before the study was closed due to poor enrollment. But here's the results. This is the allograft survival, 100%. in terms of overall survival and in terms of progression-free survival. So again, you can't make anything out of a 30-patient trial, but you can also see that this data is not too bad in terms of the potential for long-term survival. So I'm going to conclude here. Transplant for early relapsing follicular lymphoma. I think these patients have an extremely poor prognosis if they relapse within 2 years like our patient did. An auto may give a long-term disease-free survival with a low non-relapse mortality, but those patients do remain at risk. In contrast, an allo it does include powerful GVT effects, high rate of molecular remissions and low relapse rates, but it is with a higher risk of non-relapse mortality, and we should do controlled clinical trials in this population. And I'll close with this, that many groups are now looking at this population because they see this as a pathway to approval for their novel agents for other drugs. And I look forward to the rest of the debate. Thanks a lot.